Good evening. My gratitude to Professor Narayan Prasad sir for having me here today. It was my first time and it was a wonderful feeling to step into this prestigious campus. I'm here to address a very niche area of pediatric AKI, that is risk stratification and diagnosis. 4 years back, in 2020, Stuart Goldstein, often regarded as the father of pediatric AKI, nudged the pediatric nephrology community with this commentary. He asserted that the era of nihilism, which means no distinct meaning or purpose regarding pediatric AKI, was over. It became clear that children could die not with AKI, but from AKI. And the pressing question then was, what proactive steps are we taking to address this? In alignment with his vision in 2021, he spearheaded the inception of the first pediatric acute disease quality initiative, the AKI Compendium, an opportunity I was fortunate to participate in. Since then, numerous publications have surfaced, exploring diverse aspects of pediatric AKI, including risk stratification. And here are key papers that I bring to you fresh from the oven. Let me begin by highlighting the pediatric specific issues in diagnosis of AKI. Firstly, the absence of a baseline creatinine that varies with age from birth to 18 years presents a significant challenge. Secondly, there is scanty research on urine output criteria, which is relevant to this age group in relation to outcomes. Thirdly, AKI is underdiagnosed in hospitalized children, and research on early diagnosis is limited to very specific clinical settings like post-cardiac surgery and the pediatric and neonatal ICUs. Lastly, there is limited understanding of AKI phenotypes in children, a term which has just come up in the recent years. For example, subclinical AKI, persistent, transient, functional AKI, and so on. The diagnosis of pediatric AKI has evolved over years, transitioning from pediatric rifle criteria and AKIN criteria in 2007 to the KDIGO in 2012, and then to the PROC in 2018. The quest for improvement continues with the proposed enhanced AKI criteria currently under consideration. Briefly, P-rifle was adapted from the adult rifle criteria with creatinine clearance calculated from the Schwartz formula along with urine output. AKIN was proposed as a modification of the P-rifle to improve the diagnostic sensitivity to small changes in creatinine. And KDIGO, as you all are aware of, is universally widely studied and accepted as a standard criteria as it's associated with several clinical outcomes. However, to improve the diagnostic specificity of KDIGO, a Chinese group proposed the PROC, which is Pediatric Reference Change Value Optimized for AKI in Children. So here, the reference change value of creatinine is estimated from a normative data, which is based on the age and the initial creatinine level in children without kidney disease in those who had 2 creatinine levels estimated in the last 30 days. And this is a comparative table where you see the 3 criteria, the KDIGO, the P-rifle, and the PROC. And I'm just using the comparisons between the serum creatinine-based criteria. Using the PROC, the incidence of AKI was 50% less compared to that observed using KDIGO. So definitely, it was a more specific criteria to diagnose AKI. But the question was, are we in need of a highly specific criteria or a highly sensitive criteria to detect early AKI? On one hand, we are looking at early markers before the creatinine can rise, and PROC is actually doing the other extreme. It's a very specific criteria. In 2022, Goldstein and his team proposed the inclusion of urine NGAL to serum creatinine to improve the precision of early AKI diagnosis in critically ill children. Here's the framework that you see, underscores the utility of the tubular injury biomarker. in defining AKI phenotypes. When the NGAL is positive, as you can see here, but the creatinine is not raised, then it is subclinical AKI. And if NGAL is negative with the raised creatinine, it could be reversible, transient, or functional AKI. Accurate identification of children at risk for AKI is critical and involves patient factors, disease factors, event factors, and, like the previous speaker said, kidney fitness. And these are the distinct high-risk diagnoses and exposures that increase the risk of acute kidney injury in hospitalized children. Prematurity, low birth weight are some of the high-risk kids, along with congenital heart disease, transplantation, and exposures like infection, sepsis, nephrotoxins, and cardiopulmonary bypass. Now we come to yet another important issue. What are the novel AKI risk stratification or prediction tools for children? Here is a list, and I shall shed some light on each of these tools. The renal angina index, fluid overload-based scores, biomarkers, furosemide stress test, machine learning tools, and e-alert system. Talking of prediction, let's address this question. Which critically ill child will develop stage 2 to 3 AKI within 3 days after ICU admission? So again, Goldstein and his team derived this index, the renal angina index, to predict subsequent AKI by identifying 3 risk groups: the very high risk, and the moderate risk. The assessment is done within 24 hours of admission, and the risk criteria is given a score. You see the 2 boxes here, the risk criteria based on ICU admission, transplant, mechanical ventilation, or inotropic support, and another box which gives you injury criteria based on creatinine and percentage fluid accumulation. And once you get the scores for these individual boxes, you multiply them, and the total score should be more than 8. That's the cutoff used to identify AKI on day 3 of admission. A meta-analysis of 22 studies revealed better specificity of renal angina index. I'll come to that in a bit. Before that, we have 4 studies from India, 2 from Delhi and 1 from Ludhiana, that add evidence that the renal angina index more than 8 is a good predictor for AKI in critically ill children. However, a study from AIIMS, Delhi, further characterized the renal angina index cutoff to more than 12 and more than 20 to predict severe AKI at day 3 and day 7 respectively, and also was useful to discriminate the need for dialysis. This was the meta-analysis of 22 studies, and then you can see here the specificity from 77 when we used the renal angina index, or when you combine the urinary NGAL and renal angina index, it improved the specificity from 77 to 89%. Moving to the topic of biomarkers, which we have just heard a lot in the last session, Goldstein again and group in the AKI CHIRUP study identified unique biomarker combinations on admission that predicted distinct day 3 AKI severity phenotypes. You saw one figure from that paper, and this is the other figure that is related to outcomes. And you can see here that if you have a positive biomarker in the absence of serum creatinine, that is urine NGAL positive and serum creatinine negative, that is a second group of bars, a proposed state of subclinical AKI appeared to be associated with worse outcomes of mortality and day 3 AKI compared to the group where the tubular injury biomarker was negative. A meta-analysis on 92 studies revealed urine NGAL, the liver fatty acid binding protein, and TIMP2 in combination with IGF-BP7 and cystatin C to have good diagnostic accuracy in recognizing early AKI. But these were majorly used in the setting of cardiac surgery or alongside the renal angina index. We know that fluid overload is a critical component of outcomes, and this is the score, the fluid overload kidney injury score, that incorporates fluid overload severity and nephrotoxic exposures to the P-rifle criteria. And this score has been associated with various adverse outcomes. Here is a study with 150 critically ill children where combined fluid overload with creatinine was used, and as you can see here, those with fluid overload had worse outcomes irrespective of the AKI status. They had longer length of hospital stay and higher odds of mortality. The next tool studied was the furosemide stress test. The response to a single dose of IV furosemide in terms of urine flow rates have been studied in children after cardiac surgery, in infants, neonates, and found to be an effective predictor of AKI and other related outcomes. A recent study from AIMS with 51 children with AKI stage 1 and 2 proved that non-response to the furosemide stress test had a high risk for day 3 AKI and need for dialysis. At this point, let us pause and take a look at the opportunities of using these tools as clinical decision supporters. We have evidence for successful clinical decision support systems with the Ninja and the Baby Ninja, that is nephrotoxic injury negated by just-in-time action. In pediatrics and in neonates, Goldstein proposed his algorithm for children needing CRRT. And as you can see here in the Taking Focus trial, he integrated the renal angina index, urine and gal, and also the furosemide stress test to help clinical decision-making on the initiation of RRT. The next tool is the machine learning tool. We have a decent number of studies on various predictive models for pediatric AKI in non-critically ill children, in critically ill children, neonates, and a good prediction for severe AKI was observed that outperformed even the renal angina index. Well, a short time window for the intervention between the prediction alert and the diagnosis makes it challenging for giving a good window for intervention, and false positive rates are also a concern. A recent paper from the Lancet Discovery Science section revealed a prediction model of 8 factors. So you see these 8 factors on the right-hand side. Use the machine learning algorithm to identify risk for AKI. So this needs more study, but it's just showing that the machine learning models can be useful as a clinical decision support system. E-alerts have been studied in pediatric AKI with inconsistent observations. Here is the complete list of studies showing a reduction in the incidence of AKI, reduction in creatinine monitoring in few, but increased creatinine monitoring in some, no reduction in the incidence of AKI in some. So basically the findings are inconsistent yet. Before I conclude, here are fresh ideas proposed by the PADKI group. Efforts are underway to identify and characterize unique subsets of AKI in children through phenotypes or endotypes, which means subsets that share a common biology or a pathobiology. And also concepts of identifying the right therapy for the right patient, which is called enrichment. And this enrichment is crucial in the heterogeneous disorder like AKI. Enrichment can be prognostic enrichment through the AKI risk stratification use, or predictive enrichment, which is identifying a particular phenotype that is going to likely respond to a specific therapy. So enrichment is going to aid in identifying appropriate AKI therapies in future. I end with this algorithm that succinctly summarizes the future approach to pediatric AKI. Integration of e-alerts to risk assessments, use of prediction tools for early detection, categorizing AKI into phenotypes that guide monitoring and early intervention are here to stay, while well-designed research in this regard will pave the way forward. Thank you very much.